Now, okay, and I just press broadcast. So people should be able to enter the room now. Hello, everyone. Thank you for joining us today. We're just going to wait another minute or two while all the participants load up. Thank you. Hope everyone is doing well. And hopefully Professor Marsh will.
I'm here.
Hello, Jean.
Hi, Gina.
We're live now. Everyone is entering the room.
Jean.
And I'll start an introduction in a second.
Okay, that's great.
Yep.
This was a little different from last week, right?
In the order,
I had a little trouble getting on.
We didn't broadcast right away, so we didn't have to have people experience my lack of small talk skills.
Okay. All right, good.
Good to see everyone. Okay, so we're gonna go ahead and get started. A lot of people have logged on. Thank you everyone for joining us once again. I'm Keith Brown at the University of Chicago Center for Health Administration Studies. Thank you for joining us for another Spring 2020 Michael Davis lecture. As you know, the Center for Health Administration Studies, CHAS, is a health policy and services research center that develops and disseminates innovative health policy services research, and we've been doing it for approximately 70 years. Well, the center has, not. As you know, COVID-19, the pandemic has rapidly changed and continues to change the ways we live and work. As a result, CHAS has moved the lecture series to a virtual format with registrations registering from 150 to 220 per week. We are very thankful for everyone wanting to tune in and learn more about research here at the University of Chicago. The Davis Lecture Series has always featured health policy services experts from the University of Chicago and other universities to pioneer research projects and disseminate them to our audiences. After my remarks, CHAS Director and SSA Professor Jean Marsh will introduce Gina for us all, who is an assistant professor at SSA. To keep continuity and to allow the presenter to focus on presenting, I'll be fielding the questions from the Q&A box. If you have any questions, please submit them in there and we'll get to them post-lecture. The chat feature will be disabled today, and we are already recording the webinar today, which will be featured on the University of Chicago's CHAS website, which is chas.uchicago.edu. And now I'll turn the microphone to Professor Marsh to introduce Gina Fedock. It's all yours, Jean.
Good afternoon. Thank you, Keith. Good afternoon, everyone. I'm Jean Marsh, and it gives me great pleasure today to introduce Professor Gina Fedock, who is an assistant professor at the School of Social Service Administration at the University of Chicago. Her research focuses on improving women's mental health, spans the boundaries of public health, criminal justice, law, and social work. Her research includes the implementation, testing, and evaluation of interventions designed to improve the quality of women's lives, both in the community and within correctional settings. Current projects in her very wide-ranging portfolio include an examination of women's experiences of staff sexual misconduct and an investigation of the role of human rights standards on women's imprisonment, a project supported by the Posen Family Center for Human Rights. Professor Fedock is a rising star on the faculty at SSA, and I'm very pleased to have her with us today to discuss examining racial differences in suicidal behaviors and healthcare disparities in prison responses. Thank you so much, Gina.
Thank you so much for that kind introduction, Jean, and thank you so much for having me here. Thank you to all of you that are attending. I really appreciate your care in this topic. Would you like me to go ahead and share my screen?
Yes, go ahead and share your screen.
So that, do you see the first slide?
Looks great.
All right, wonderful. Well, thank you again for that introduction, and thank you again for having me today. First, we'll be talking about suicidal behaviors in prisons and examining racial differences in suicidal behaviors and healthcare disparities in prison responses. As you can see, I have a great research team that has worked with me on this project. I also want to say that this work has been supported generously by Chaz through a seed grant. So thank you very much to Chaz for supporting this important work. I also want to mention that Deb Bybee was an expert methodologist trained in the field of community psychology. She was crucial in offering support for this project. She also passed away in September of 2019. So I also want to mention her and have been thankful for all the support that she has provided. So today's topic, again, is focused on suicidal behaviors in prison. And I want to say at the start of this talk that I will be discussing different methods and different issues related to suicidal behaviors. And so I encourage you to take good care of yourself while you're listening. And I realize that these can be very personal and triggering topics as well. So when we're talking about suicidal behaviors in prison, first, the national suicide rate for incarcerated adults in the United States is 3 times the rate of adults in the community. And we also know that suicide is a leading cause of death in prisons. It's the second leading cause of death in prison. Suicide is the leading cause of death in jails. This has been a persistent issue over time. Whenever we're talking about suicidal behaviors, though, the CDC encourages that we talk about suicidal behaviors. That means including both fatal and non-fatal suicide attempts. Within the field of research around suicidal behaviors in prisons in particular, there's been debates around whether or not we want to discuss looking at self-harm versus suicide attempts, because oftentimes this requires knowing intent. Some researchers have really stressed that we need to look at the range of fatal and non-fatal behaviors, in particular because self-harm acts can actually be quite fatal. So there's an encouragement of looking at the range of sort of fatal and non-fatal suicide attempts within prisons, and to really focus our prevention efforts on understanding the variety of behaviors that occur. While we don't have national prevalence data around the rate of suicide attempts within prisons in the United States, there's one study that did a medical record review of over 10,000 incarcerated adults. And the study found that 3.4% of these records included a mental health diagnosis of suicide attempts. And about 94% of these attempts were done within the actual prison itself. So we look at this as quite a high rate. What we also know is, as we consider suicide prevention efforts and intervention efforts, we also know that we have opportunities often to intervene, as about 40% of incarcerated adults who die by suicide often have a history of a prior attempt while in prison. So for example, one study of prison suicides found that 28.6% were the actual first attempt, 19.6% had 2 attempts prior, or this was their second attempt, excuse me, and 51.8% had multiple attempts over time. So we want to look at how we're responding to suicide attempts, as also to think about suicide prevention in the future as well. When we look at national and international suicide prevention standards, they suggest that staff and prison staff should be offering immediate physical health care after a suicide attempt. And this is to address any injuries and to promote stabilization. And there should also be the provision of mental health care immediately following a suicide attempt. And again, these are framed as really important prevention strategies. What we also know, in contradiction to this, is that most commonly prisons have a policy and practices of actually punishing incarcerated adults when they attempt suicide. And oftentimes, as a result, they're actually placed in segregated housing, which is more commonly called solitary confinement. It's seen as isolation as a form of punishment, with oftentimes regular watches, but this is considered more of a punitive than offering physical or mental health care. One study of California prisons, of suicides within California prisons, looked over 10 years of data and found that about 60% of the suicides, the death by suicides, would have been preventable or at least foreseeable had staff responded to prior suicidal behaviors with treatment-focused responses, such as providing physical and mental health care versus providing punitive responses, particularly placement in segregated housing units. So as we think about really suicide prevention and intervention, we can look at these decisions made post-suicide attempts as an area where we can focus some of our change efforts. Unfortunately, though, the research that is available is quite limited in understanding what factors predict how staff respond after a suicide attempt. And in fact, our research base in terms of even understanding the rates of different decisions that are made by staff is quite limited. Whenever we look at the literature around factors connected to suicide attempts, we see that there's a robust literature around individual, incident, and institutional risk factors that are connected to the risk of suicide attempts or death by suicide within prisons. So in a vast majority of literature, it's really framed as a white male problem within prisons because of the high rates of suicide for white men. It's also, we can see that the lethality of method is one risk factor, that particularly the use of hanging is a common method, and that can be quite lethal for incarcerated adults. One of the strongest risk factors for a suicide attempt, but more so for suicide completion, death by suicide, is placement on a single cell housing unit. So we think about the segregated housing unit, solitary confinement, and this placement increases the risk of death by suicide 400 times relative to placement on a multiple person cell unit. We also know, looking at sort of research based in national data, and we even look at the way that the Bureau of Justice Statistics has reported around suicides within prisons, is that it's important to consider differences between prisons designed for men and prisons designed for women. Because what we see within these different prisons is that we often see different types of mental health care that's available, different rates of treatment. We know that gendered forms of social control within these. So for example, there's literature around staff's perceptions of incarcerated women and their suicide attempts. Their suicide attempts are more likely to be seen as emotional, acts of emotion or emotional manipulation. That's the way in which staff talk about them. So when we look at suicide attempts, we want to look at what's occurring within prisons designed for men and what's occurring within prisons designed for women. And again, we understand risk factors in relation to suicide attempts and deaths by suicide, but we know less about what predicts actually the provision of healthcare post-attempt. So when we look across the existing research, we often see a reliance on a single theory. So we see that within the existing research, commonly there's a perspective of looking at prisoner suicides, which is really understanding what individuals bring into prisons. So this idea that we can understand the high rates of suicides within prisons by understanding individual factors, looking at past histories of trauma, looking at past histories of mental health issues, looking at demographics. There's also a body of research that looks more at deprivation, understanding the prison environment in relation to the high rate of deaths by suicide within prisons. And this research looks at suicides in prisons to really emphasize the environment. And many researchers have called the need for integration of these perspectives and to really understand the ways in which there are dynamics across factors. Also, if we look at the way this suicides within prisons is framed, it's often framed as incarcerated adults are considered a vulnerable population in and of themselves. And so we have a lack of understanding of really subpopulations of risk and understanding sort of variance in terms of are there different risks for different populations within prison settings. And as already mentioned, we definitely have a lack of research examining how prison staff respond to suicide attempts. Qualitatively, prison staff had said that they most commonly respond by placing incarcerated adults within segregated housing units in terms of, so they often have a more punitive response. So we don't know who is more likely to receive punitive responses, who's more likely to receive treatment responses. We want to particularly pay attention because punitive responses can exacerbate future suicides. And we also want to understand the greater context of proportionality that occurs within mass incarceration itself, which is driven by macro level mechanisms. And then we also want to understand the ways in which racial differences occur within treatment of incarcerated adults within prisons. So for example, research has found that Black incarcerated adults have a higher rate of being sent to segregated housing in general than white incarcerated adults. So in terms of taking this together, we really want to understand more around how staff responds and who receives what sort of responses by staff after a suicide attempt. So the research that I'm presenting today is really based on a study that has 2 phases, and there are 2 research aims as well. So the first research aim is to examine suicidal behaviors in men's and women's prisons, and then to identify subpopulations based on behaviors, and then in particular to identify any potential racial differences. Our second research aim is to investigate prison staff's responses to suicide attempts to assess for healthcare disparities. So in particular, we want to identify predictors of the receipt of healthcare post-suicide attempt and to identify gaps in the provision of healthcare. So today I'll be focusing on phase 2, but phase 1 included MEFEC's logistic regression, in which we examined individual, incident, and institutional factors associated with staff responses to suicide attempts. In particular, we wanted to know which factors predicted the provision of physical and mental health care. So first we had many, and we found different models of predictors in men's prisons versus women's prisons. We also saw that race was a significant predictor in some of the models, as well as some forms of methods. We saw that placement in a segregated housing unit was also significant. So based on understanding the ways that variables were significant, we really wanted to do phase 2 with latent class analysis to better understand the patterns of the data, to really understand how are these variables operating together. And are there sort of subpopulations based on these patterns? And how can that help us refine our treatment of different subpopulations and really tailor our prevention efforts for specific forms of risk? And we wanted to be very attentive in this phase 2 to race, to the methods of attempts, to housing unit, particularly segregated housing. So for this study, we used administrative data. We specifically used critical incident reports, which were required to be completed by prison staff within 24 hours of a suicide attempt or death by suicide. As 5 years of administrative data from 5 different prisons. 3 of these were prisons designed for men and 2 were prisons designed for women. They were Midwestern state prisons within the same state. And there were a total of 518 incidents that the prison had identified as related to suicidal behaviors in some way. We also supplemented this administrative data with the Department of Correction data, in particular to understand demographics or to gather demographic information. So first of all, we're limited by the identities used within the Department of Corrections. So gender in and of itself is very binary. It's men and women based on how the Department of Correction defines that. Racial identity is also limited to what the correction system calls white Caucasian and Black African American. So we have those 2 categories. So we combine this data. And within the critical incident report domains, we were able to find out information around how the staff classified the event. What type of incident did they say it was? We were also able to review the summaries and code for the method that was used in the suicide attempt. We also had information about the location of the attempt, if it occurred within the general housing unit, a segregated housing unit. We were able to look at reason for attempt in terms of how staff had coded the reason for the actual suicide attempt. Full disclosure, we ended up dropping this variable. I include it here because, as I mentioned earlier, with intent and understanding suicidal behaviors, we weren't able to use this variable because in about over 90% of these, over 90% of the incidents for men, it was staff had deemed it an unknown reason. Now I can tell you, I'm happy to talk about the Q&A, but in terms of the summary, summaries of the incidents, we often saw reasons, but the staff still hadn't labeled it as such or identified one. And in terms of the incidents for women, we saw that about 50% of them were identified as having some emotional reason. It was just emotional, feeling emotional, versus unknown by staff in terms of why the attempt occurred. We also saw that we were able to see with the critical incident report domains, we could see what the immediate staff decision was. So did they apply physical restraints? Did they write a misconduct report? Did they request healthcare in the facility or healthcare outside of the facility? And then we were able to see what the next action was by staff. Place the adult in segregated housing unit. Did they provide them with health outside the facility? How did they respond? So again, we used latent class analysis to identify subgroups of individuals with similar item response patterns. We labeled all the variables as binary variables, so placement in segregated housing unit or not, and different methods. We used statistical fit indices to identify the number of classes to be used. And then we did a 3-step procedure for examining race, in which it was coded 0 as white Caucasian, 1 as Black African American, as a predictor of classes, and then the distal staff outcomes. And then we did analyses within those prisons designed for men and the prisons designed for women. So of the 518 incidents, 161, which is approximately 31%, were connected to women. And of the 161 incidents, these were attributed to 3 women. 41 were Black African American, which makes up almost 50%. There was a range of 1 to 13 incidents per adult, and the average age was 33, but the adults, the women ranged from ages 17 to 62. There were 357 incidents for men, and these were attributed to 207 men, 43% of which were identified by the Department of Corrections as Black African American men. There was 1 to 18 incidents per adult. They also had a similar age range with a mean age of 30. And I just want to say, in terms of within the state's correctional system, about 47% of incarcerated adults were Black African American within. This is representative of that already existing racial disproportionality within this state prison. So we have some basic demographic information. You can see in terms of there was the way the staff labeled the self-attempt, the suicide attempt behavior. You can see in terms of method that the most common method for women was around hanging or suffocation, whereas the most common method for men was cutting. You can see that a majority of women's incidents, a majority of women had an incident that occurred within the housing unit, whereas a majority for men occurred within segregation. We'll also be talking about these immediate actions in the next few slides. So in terms of identifying classes, we used the AIC and the BIC to help identify, and we saw that the ideal number of classes for men and women was 3 in terms of looking at having a lower BIC as well as one of the lower AICs. All right, so I'm going to walk you through this in terms of the classes that we identified first for women and then the classes that we identified for men. So first, and for the classes identified for women, you can see class 1 is this sort of burgundy red dotted line. They first had a low rate of multiple incidents. So most of the incidents were single incidents. They also had somewhat of a low likelihood of being in segregation at the time of the incident. You can see did not really use hanging or suffocation. They used a method of cutting. They had some attempts that involved drug overdose, and they had almost or about average likelihood of being considered their incidents considered attempted suicide. So we think of that class 1 as really involving cutting or a drug overdose. In terms of class 2, we can see that they were mainly single incidents, that they had a somewhat higher rate of being in segregation. They primarily used a method of hanging or suffocation. They did not use a method of cutting or drug overdose, and they had a high probability of their incidents of attempted suicide by the prison staff. And then finally, class 3 is this yellow dotted line. And for class 3, you see that they have a high likelihood of multiple attempts, a high likelihood of being in segregation, a high likelihood of using multiple methods, so hanging, cutting, and drug overdose, and with a high likelihood of being considered an attempted suicide. I want to provide some quick clarification about drug overdose. That there are overdoses, and they're also what was deemed by the prison to be if someone swallowed too much of a medication, they put something in, they ingest something that was too much of it, or it could be a potentially fatal amount. All right, so we have these 3 classes, as you can see. The first, which is more cutting and drug overdose, class 2, which is mainly hanging and suffocation, and then class 3, which is multiple attempts and methods. Next, we looked at how does race predict class membership. So what you can see, again, with race, which one coded as Black African American, that Black women had a much higher likelihood of being in class 2 than in class 1. And to remind you of what this means, is that class 2, again, is this purple line that's more likely to have single incidents with a little bit higher rate than class 1 of being in segregation, mainly by hanging and suffocation. So next we wanted to look at what happens with these classes, these subpopulations after their attempts. What are the responses? So you can see that for each type of response, the use of physical restraint, a misconduct report was written, medical facility was called, and within the facility was called, medical assistance from an outside hospital was called, placement in a civilian hospital, and segregation is the final outcome for the outcomes. You can see that across these, that there was a high likelihood of, or high rate of medical care within the facility being called immediately upon staff discovery of the event. If you look closer at medical assistance requested from a civilian hospital, significant differences. So you can see that class 2, which is the middle class, and is the one in which Black women are much more likely to be within, has the lowest rate of outside care being requested. So again, these are mainly attempts involving hanging or suffocation. And then whenever we look at placement in the civilian hospital, again, class 2, it has the lowest rates of receiving this outside care, which arguably should be better care than inside care. And then they also have a higher rate than class 1 of ending up in segregation. So when we looked for statistically significant differences, again, there was a statistically significant difference in terms of that request for civilian or outside-based healthcare for class 2 versus class 1. And I just want to point out that, you know, you can see class 3 has a higher everything. While they have the highest rates of having healthcare requested, they're also having the highest rate of placement and segregation. These are folks, again, who have multiple attempts and are more likely to already be in segregation when it occurs. So when we also looked at results for men in terms of classes, we also found 3 classes. So class 1, and again, dotted red line, kind of red and burgundy. You can see for class 1 as well that they mainly had single incidents, that they were almost average likelihood of being in segregation at the time of the event, a low rate of using hanging and suffocation, high rate of using cutting, low rate of drug overdose, and these were sort of above average likelihood of being labeled as attempted suicide in terms of their events. For class 2, which was the solid purple, you can see that they also have sort of a low rate of multiple incidents, a high rate of being in segregation of the attempt, a high rate of using hanging or suffocation as a method, a low rate of cutting or drug overdose, and a high rate of having their incidents being labeled as attempted suicide. And then lastly, you can see class 3, which also has mainly single incidents, the lowest rate of being in segregation, a low rate of hanging and suffocation or cutting, but a high rate of drug overdose, and the events are also around half as likely to, or have an average likelihood of being labeled as an attempted suicide event. So again, we have this 32% of this population that's mainly engaged in cutting, another population that's mainly engaged in more hanging and suffocation, and then the third group, which is mainly engaged in drug overdose. And these all have high rates of being considered attempted suicide. So we looked at how does race predict this class membership. And similar to the results for women, I can tell you that Black men were more likely to be in class 2 than class 1. They were also more likely to be in class 2 than class 3. So that's really identifying, again, the solid purple line, this class 2, that Black men are most likely to be in this class that involves mainly single incidents, high rate of being in segregation, mainly using hanging or suffocation, sometimes cutting or drug overdose, high rate of incidents that are considered attempted suicide. So when we looked at how does class membership predict how staff respond, you can see that with the use of physical restraint, that class 2 has the highest rates of physical restraint upon staff discovering the incident. And again, this is a class that is significantly more likely to involve Black men. You can see that assistance from the outside hospital, that here again, class 2 has the lowest rates of this type of assistance being requested immediately by staff. And again, this is the class involving Black men. Is more likely to involve Black men. And then also class 2 has the lowest rates of receiving care from an outside hospital. You can also see that segregation, there's a high rate of cutting, with the second for the class involving hanging suffocation, and the third involving more of this drug overdose. So what I want to stress first is that we can even look at the rates of results here and see that there's a higher reliance on using segregation and on actual outside medical care. So again, this is our results that can show that there's a statistically significant difference between class 1 and class 2 in terms of staff calling for medical care outside medical care. And while it wasn't significant in the difference between class 1 and class 2 in terms of actually receiving health care, that could be because of the low rate of actually requesting it for class 2. So what is this telling us? This study results are showing that what we have are these 3 different classes within prisons designed for men and prisons designed for women, and that we see actual subpopulations, and that there are racial differences in suicidal behaviors, and that the ways in which these occur, the ways in which prison staff are responding to this is creating sort of health disparities in terms of who's receiving what type of care. And whenever we see these differences in suicidal behaviors, it's quite concerning, because there is a history and a sort of ongoing concern around the underreporting of deaths by suicide for Black incarcerated adults. And this also connects to larger outside community-based literature that talks about how the way that we frame suicide risk factors and sort of who we center often shapes how we view behavior. So in the determination of what was the intent, why did this occur, if you're looking for the age range and this person doesn't match, then how does that shape how you actually see the behavior itself? And there are racial differences in terms of suicide risk factors. But we want to understand, for example, the role of lack of belonging, the role of stigma, the role of racism, the role of stressors that are race-based stressors in the incident of suicide attempts and death by suicide. We also know in community-based literature that we have a great need, especially within the field of suicide prevention, to really focus specifically on racial minority adults. National prevalence rates show us that Black incarcerated adults have a much lower rate of suicide, death by suicide, than white adults, but the rate is still not at 0. So first, we can look at that lower rate and look at what can we understand about why this isn't happening as much to inform our efforts. We look at how do we still prioritize and center those experiences and center them to understand the experiences for various racial minority groups. I mean, one of the major limitations of this data is that it is a sort of Black-white divide, when we know that there are multiple racial identities that are severely lacking within this research. And then also, this study really identifies healthcare disparities post-suicide attempt, and this may connect to larger racial differences in treatment of incarcerated adults within prison. So we know that other existing studies have shown that incarcerated Black people get segregated housing and mental health care in comparison to white incarcerated adults, both in jails and prisons. And so really understanding, I mean, we also don't know based on this study, like the quality of the care that was received. And so that's another factor. So part of it is looking at within this, the punitive that exist, who is deemed more punishable and who's receiving types of care that connect to sort of long-term outcomes. And also this implication, I would like to stress that we need to, whenever we're thinking about importation and deprivation factors, these staff decisions really reflect this sort of dynamic that is taking into account both the deprivation and the importation factor. And even whenever we conduct research, we need to talk about the racial disproportionality within the institution that exists. We need to understand the racial disproportionality within the state. In terms of state averages, the national average for death by suicide within prisons is 16 per 100,000 adults. Well, this goes up to 43 and it goes as low as 8 in West Virginia. So we really need to understand what's happening across state levels and how is this maybe linked to racial disproportionality within actual specific institutions. We need to understand these factors. We need to understand the impact of racism within these spaces as well. Types of care are available and are actually provided. And as we think about practice implications, to really expand our prevention and intervention domains to understand the variety and nuances of combination of factors that go into suicide attempts. We can keep looking at risk factors, but understanding more the patterns and to understand more about tailoring intervention efforts. And on a larger scale, I mean, other researchers have said that preventing death is beyond just suicide watch. In our first study, we found that direct observation, this kind of watch with no care, was provided in over 60% of the time in incidents, and that this was mainly the sort of form of outcome. This and the use of segregated housing, which has been called a human rights violation, which has been known to exacerbate and to actually cause harm in multiple ways. How can we think about other responses beyond these forms and to actually put that into policy? And lastly, I mean, there are multiple limitations within this study. And we also want to think about, ideally, we would have longitudinal study research that it really follows folks from the time they enter to the time they exit, and to really look at their experiences over time, to look at how the rate and the attempts are impacted by changes in policies and practices, and again, to really keep in context the different power dynamics that are. I do want to take one moment to bring this into the context, the water within which we're swimming. With the COVID-19, we know that this is a particularly harsh pandemic for Black adults within the United States, and that this is, I want to bring attention to the fact that we know that people are dying within jails and prisons, that they're being neglected, that there's a lack of sort of basic soap, antibacterial products. We know that within these spaces in which privacy is exactly what you're being denied, that any idea of distancing or sort of protection from disease is also a rarity. UCLA is doing a behind the bars data project that they're updating daily. These are numbers from Sunday, but where they have staff that are looking at rates of confirmed cases in state and federal prisons and immigration detention centers and jails. There's a number of confirmed cases. There's a number of residents who've recovered. There's a confirmed number of deaths. We also know that there are a variety of different federal and state responses. For example, in Illinois, we've seen the governor grant medical furloughs, as well as releasing pregnant adults and releasing mothers with infant children. We know that there's also a push towards releasing those within their outdates. We have data that's just about numbers. In terms of adults, we aren't able to see what racial disparities exist that I know of, like in terms of the DOC information that's being posted. So if anyone knows of that, feel free to share. But I stress that I think that we see these kind of racial disparities across multiple domains remains within prisons. And so the way within prisons right now could be extremely horrific for incarcerated Black adults, I think is an urgent call for action and an urgent concern for us to keep thinking about how might racial disparities be existing here and how might our treatment responses really need to take that into account. So thank you so much for your time and for your attention. I'd be happy to take questions at this point.
Can you hear me, Gina?
Yes.
Okay, great.
Yes.
I don't know why my video is not showing, but no matter. We do have a couple of questions. That was a wonderful lecture. I can see that the Chaz seed grant funding went to a lot of good, important work. I'm going to build off the first question that came in, which is, it looks like you analyzed pretty extensively those critical incident reports, and it demonstrated how many different incidences result in attempted suicides and taking one's life. Is there, is taking one's own life the leading cause of death in prisons? And if not, is it ranked fairly high compared to other deaths in prison communities?
Right. So suicide is the second leading cause of death in prisons. It's the %1 leading cause of death in jails. And I mean, this is second to disease. And so, I mean, we're talking about, about 7%, 6 to 7% of mortality within prisons. And it has been a persistent problem. The rate of mortality, the mortality rates were not collected until 2000 within state prisons. And so state prisons only started routinely collecting this information in 2000. And they collected it just from men and women's prisons, and then they started collecting it with more demographic information in 2015. Answer your question?
Yes, yes. Building on that, someone else asked if there is data on, if you know of any data or kind of some numbers in your research that indicate violent acts that are most probable to result in death. For example, death by other prison inmates, or potentially even death by workers or an officer there.
So, there is a report on the Bureau of Justice Statistics website around measuring and identifying cause of mortality within prisons and jails. Not the lightest read in terms of topic. I laugh out discomfort because it's a very tricky process.
Yes.
So I'm just trying to think. I mean, I know there are accidents, illness. I would have to go back to look at the mortality reports. I don't focus typically on attacks by others.
Mm-hmm. Maybe is there a resource that if somebody was interested in that data or investigating further that you would recommend that they go to?
Yes. So again, at the Bureau of Justice Statistics page, they have statistics related and reports related to specifically forms of mortality. And you can see them, the reports for every year that are posted. There's great statistical information just for prevalence around related to race and gender in terms of correctional populations in jails and prisons, probation and parole. So it's a great source of information. There's also information around PREA data. So if you're interested in rates of staff sexual misconduct, victimization by others while incarcerated, that doesn't result in mortality, that there's also information about that through the Bureau of Justice Statistics.
Great. Thanks for those referrals. On to the next question. How predictive is the sentencing offense in understanding the prevalence of suicide behaviors, the methods used, or system response when attempts are made?
Right. So we found that about it was 49% of our sample had was serving time for a violent offense. And actually it didn't hold as significant. And in our early analysis, we looked at type of offense, and then we condensed it to violent versus nonviolent offense, and we didn't see differences in those two. I think, though, that this ties into, the question of incidents that are occurring within segregation. I mean, we had housing unit, but we didn't necessarily know security. So what we do know is that type of offense correlates to the level of risk that prison staff assign to incarcerated adults. It's part of the determination of which housing unit you'll be on, what type of treatment you'll receive. So that partly feeds into where people might be placed, and also how they might be treated and how severely their risks may be assumed. So for example, whenever we think about these staff decisions, I mean, obviously future research may want to interview staff post an attempt and say, like, what went through your mind? I mean, we also know that staff not taking people seriously when they say they're going to harm themselves has led, I mean, it led to huge changes within Canada for their prisons for women, because a woman killed herself while staff watched. I mean, this led to it that really changed the ways in which incarceration occurred. So we know that there's a risk of also neglect. So when we bring this up, if someone is seen as potentially having the means to be more violent, how is that maybe leading to a more punitive response, or how are actions taken versus someone who may be in for a nonviolent, serving time for a nonviolent offense. So I think this really ties into how people are perceived and how risk is perceived in multiple ways.
To kind of continue that discussion, someone was asking, have you come across research data that demonstrates proactive mental health treatment support groups intervening, and if that could be a model for humane rehabilitation practices?
Well, one factor that actually I've heard many times in interviews with women who are incarcerated is the need for peer support. So even in looking at the incidents, I think about 40% of the incidents that occurred within non-segregated housing units in women's prisons were actually a peer notifying staff that someone needed help. And we often hear qualitatively that folks saying, like, we watch out for each other. We know when each other have, days, anniversaries of court cases, anniversaries of events, or our kids' birthdays. We know our sort of triggers, and we know, holidays that we need to watch out for each other. So some of the interventions that have been tested have been more peer support models. And, this is tricky. So for example, in Michigan, they allow women serving life sentences to serve as sort of peer watchers on the segregation unit. It's the highest paid job in the prison.
Wow. But
you are interacting with folks who've attempted suicide, who are now sort of stripped down and placed in isolation. And women serving life sentences have also talked about, in doing that work, it triggers their own memories of their own attempts. And part of serving the life sentence is this constant idea of, like, will I die in prison? Their own sort of suicidality considerations. And yeah. Have support. They don't get support for doing that work in terms of how it impacts their mental health. Yeah. And whenever we talk about mental health care within prisons, we're often talking about medical management. We're talking about, so in Illinois, for example, women who are incarcerated often get 15-minute visits through telehealth with a psychiatrist to really discuss their medication management. So when we're talking about suicidality, to think about, what is sort of the culture, the institutional culture, again, how do we think about support and risk? How do we think about the strengths that are already there in terms of caring for each other that may be occurring? And then how to support those who are really doing the work of trying to keep people alive, yeah. Which is that peer-to-peer support.
The next question is kind of two parts, but it builds on what you just said about there potentially being triggers somehow from communication. Do you have any sense of how different lines of communication with family members and friends, whether email, video calls, phone, may elevate or dampen the risk of suicide and suicide attempts? And are any such dampening effects of outside communication conditional on costs that private industry sets to make use of such technology?
Yes, so first of all, placement and segregation results in constrained, if at all, communication with others. So if we think of social support as key, and then your response to someone's suicidality is to place them in a place in which they're basically stripped down and handcuffed and denied opportunities to interact with their social support networks, I mean, that can exacerbate any sort of feelings of hopelessness or disconnection. Mm-hmm. However, the other issue, it's not however, it's an and issue. That oftentimes interactions with folks on the outside can contribute to suicide risk. So it can be a fight with a loved one. It can be a caregiver saying, I'm not going to bring the children around you anymore. It can be related to the loss of a court case. There are a variety of factors, both within the prison and outside the prison, that can impact. So I know in an interview with an incarcerated woman, she said she found out her daughter had attempted suicide and no one gave her information for days and she couldn't get it. And she was like, I feel so powerless, and this is the way I felt like it made me feel this level of hopelessness. So whenever, and I know if there's anyone from class last quarter around criminal justice, clinical practices with criminal justice populations, we had our guest speaker, and her name is still on my mind, who was the warden of Cook County Jail, and she was actually talking about how they actually started a suicide prevention based on listening to folks' phone calls, because oftentimes arguments with folks on the outside were linked to suicide attempts or worsening mental health inside. But that gets into privacy issues. And so it becomes this line of protective versus surveillance within an environment that's based on punishment and control. That's why I encourage us to think about incarceration, to think about if we're actually centering more than just preventing someone from dying, but thinking about improving quality of life, can we think in a richer, fuller way about this? And profiting off of contact is intrinsically tied to the criminal justice system in terms of the cost of phone calls, the cost of stamps, the cost of video conferencing. All these things are very expensive, especially if you're thinking about, like in Illinois, folks get $10 a month. And if a call is, several dollars, then how are they going to get soap and how are they going to get other basic necessities?
Okay, I'm just gonna keep going
answering these questions.
Yes, no, these are great, and you have great responses, very informative. Can you speak on or discuss research that may exist on suicide attempts or taking one's life amongst juveniles and young people in prisons or jails, and challenges associated with obtaining that information, and similarities you see with your research concerning adults?
Right. Yes, and so I'm happy to provide also information through the Bureau of Justice Statistics. I believe there are also reports for juvenile justice. I was actually just working with a doctoral student here at SSA, Tammy Thurman, who was looking at data for juveniles, and we were looking specifically at suicide attempt rates. I mean, one of the risk factors is actually being 17, being younger. And so there are two things, like thinking about juvenile justice, the juvenile justice system, and then thinking about young people who are housed within facilities designed for adults. And within the facilities designed for adults, being younger is actually a risk factor. That sort of 17 or under is a risk that they have a higher rate, that population has a higher rate of death by suicide within settings for adults, which is tied to multiple factors and the sort of neglect that occurs within those spaces. And I mean, so I'm curious with the person who asked this question, what's just more details around what specifically you would like to know in relation to juvenile justice. I think we see a lot of these same issues around what we take seriously as a concern, the role of racial disproportionality, the idea of who's seen to be a risk in what types of ways, the lack of provision of proper care and services learning how to adequately screen and when to screen, not thinking of sort of screening as a one-time event, but as something that happens on an ongoing basis. So again, I hope I answered that question.
Yeah, the follow-up question is, do you see method differences?
You know, I don't, because I focus on adults, I don't feel comfortable answering that question right away. I don't want to give a wrong answer. I will be completely humble in that way. I care about children and I care about young adults, but I want to give you information. Correct.
No, that makes sense, and they can follow up with you. Your contact information is on the SSA website, so they can send you an email.
Yeah.
Similarly, somebody was asking about the research and efforts seem tied to an intersection between restorative justice in prisons and mental health advocacy. Policy efforts resulting from this research seem restricted to the available data. So again, it's kind of about accessing data. What are the different limitations that hinder the ability for research to advocate for restorative changes? And do you feel those might be tied to specific systematic or institution limitations?
Well, let me also, I have to answer this within the context of saying thank you again to the CHAZ-C grant, because as part of this funding, we actually tried to request additional critical incident reports from other prisons, because we wanted to actually do like a sampling based on sort of rates of suicide and the rates of racial disproportionality. I can tell you from one state, they said, oh, we'll send you, we have like 13,000 incidents from 5 years, we'll send you data, we paid for it. And they sent us Excel spreadsheets where they had broken up the data. So they had lines from their actual critical incident reports in one file, and they were, a lot of it was redacted. They had demographic information in another, and sort of like some other demographic. I mean, it was broken up to the point where like you couldn't use it, and they had removed so much information that we really couldn't use it for analyses in ways that would make sense. We also tried to obtain similar types of information from other states. Accessibility of information, like this is what's happening in real-time decisions within prisons. Getting access to that information is so crucial and it's so logistically difficult. Like we, even as part of this project, reached out to a lawyer who has experience doing FOIA, the Freedom of Information Act processing, with a national organization, as well as here in Illinois. And she said, basically, you're going to be looking at, if you try to FOIA information, you're going to be looking at waiting for years, where they give you a runaround, and getting incomplete data, and also risking, getting pushback. You have to know exactly what you're asking for, which is why networks of support are so important. To know what the title of the form is. You have to know what type of, is it classified as HIPAA data or not? So to understand what is happening in these real-time decisions is crucial information that the institution does not freely give away. So we want to understand prevalence and really think from that importation perspective of like, here are numbers of people, but even trying to get data, national data by race and gender. Like understanding, when you look at the mortality data, you can look by gender, you can look by race, but you can't look by race and gender. And so that's why it's so important for research for us to look at some of these forms of analyses to really push for deeper understanding, and for us to call out in our research methods and our research questions and our the ways in which we're handling the data to show the ways in which change needs to occur, and to draw attention to power dynamics that are not being readily explicit in the existing data that's provided. Does that make sense?
Yes, absolutely. I think that's a great.
No,
I think that's a great answer. We fielded a lot of questions, I think, concerning the access of data and institutional access, and so I think that was a very comprehensive answer. Prisons and jails are being asked to house people in single-person cells to prevent the spread of COVID-19. You mentioned solitary confinement increases the likelihood of suicide attempts. What recommendations do you think can be advocated for in prisons and jails to decrease those attempts for people in single-person cells?
I mean, first, there are multiple organizations and policymakers, social workers, advocates of all types and nature that are really saying that we need to decarcerate. That right now, humane response is to get people out of prisons and jails, particularly right now where we know like nursing homes, which are comparable, immigration detention, in which the rate of positive cases is just exponentially, the risk is increased. And so, I mean, but if we're talking about like working within the system, we often are then constrained to what resources are there. And so when we talk about using isolated housing as a form of preventing disease, we're caught between two really bad decisions if we're limiting it to not decarcerating. And so part of this is looking at, many people would say that it's an oxymoron to say humane segregation. You know, I've seen that in segregated housing units, for example, in Illinois, you can have 15 minutes in sort of a general space, but you're still handcuffed and you still can't really not be guaranteed that there'll be other people in a shared space and you're still being heavily supervised. You know, again, I want us to think about like what quality and what standards we're using. And to think about really promoting wellness and to think about promoting well-being. And to think about the role, you know, I think about as a social worker, the sort of ethics of these different decisions. Obviously, if it's between someone who's medically very vulnerable, if it's a choice between having them in a housing unit in which they're with 6 other people or 7 other people versus, you know, being alone, I mean, that's a really difficult medical decision. And I would argue more that we need better choices. We need better, this is an opportunity as things kind of fall apart to think about how else we could do things. And so I really follow the advocacy efforts that are happening across the country around really rethinking the role of incarceration and really rethinking the conditions in which we place people.
We still have 2 more questions. Are you okay? I know we're at the 1:30 mark. Someone was asking, as we know from your presentation that you focused on 2 racial groups representative in the prison population. At the same time, did you come across data for other racial or ethnic groups? And what are your thoughts about being a minority in the prison system and how it impacts mental health?
Yes. So again, you know, we found that about 40 to 49% of the women and men involved in these incidents were Black African American, which reflected the racial demographics within the state at that time, within the state prison system. In looking at the existing research, you can see that there's actually there's like the highest rates for white incarcerated adults, and then Hispanic Latinx is the second highest, and then Black African American, and then there's this other category which we see that there are critiques of using that really encompasses Asian Pacific Islander, Native American, American Indian populations. You know, part of this, what I hope this research does is say that we have to center different racial populations. To have a study focused on the experiences of prison and healthcare responses and treatment by staff specific to like Latinx women would be really important research to be done. There are gaps in understanding this experience. And even more so, again, because the body of research around suicides in prisons has been framed as white male problem, I think it's really ignoring, again, many of the issues that are specific to various populations, and to think about the role of gender, class. I mean, we don't have sexual identity, gender identity included. And we know that, again, these demographics reflect deeper power dynamics and differences in treatment and perception of problems and perceptions of risk. So I think that this just pushes for the need to really focus and to gather more information and to, and to center and just focus on one population to understand these dynamics.
Great, that makes sense. I think that's the end of our questions. I think most of the other comments have been answered with your responses. So I will thank you now for a wonderful presentation. People were asking about accessibility. I'll try to get any video content up on the CHAZ website as soon as possible. And your slides are already featured on the Davis Lectures website. So people can follow up with those slides and shoot you an email if they have questions.
All right, great. Thank you so much. And
Thank you so much, Gina. I really appreciate it. Thank you everyone for watching, and hopefully we'll see you next week. All right, bye-bye. Take care. Stay safe, everyone.